Hello, everyone, and welcome to your week 13 post-exam 3 lecture. So, we're going to start out today talking about genetics, and I am just going to go through the basics. A lot of it, hopefully you'll remember from any A&P and biology classes you may have taken. You should remember most of it anyway. All right. So, what is genetics? Genetics is the study of genes and pretty much their role in inheritance. It determines how many certain traits or conditions are passed from one generation to another. Um, it began with a pea plant experiment in the 1960s in Austria. A monk named Gregor Mendel discovered how traits are transmitted from parent to offspring while experimenting with pea plants. And this is what led to the study of genetics. Just a little fun fact. Genomics. So, when we're talking about genomics, this is the study of all of an individual's genes, also known as the genome, and how they interact with each other and the person's environment. It includes the study of complex diseases such as heart disease, asthma, diabetes, and cancer. Um, these complex diseases are included because they are typically caused by a combination of genetic and environmental factors rather than by a single gene. When we're talking about genetics and genomics, they have a profound impact on health and disease. They play a big role in 9 of the 10 top leading causes of death in the US. So, understanding how it influences disease can lead to significant changes in healthcare. Um, Understanding the causes of some of the most deadly diseases, such as heart disease and cancer and diabetes and stroke and Alzheimer's disease, this can greatly influence the health of Americans and the role and what role lifestyle really plays in their longevity. So, these are the basic principles of genetics. We're talking about genes. Genes are the genome. The genome is an individual's genetic makeup. Genes are basic units of heredity. Um, there are over 22,000 genes that make up each person's genome. They carry the instructions for proteins that direct the activities of cells and functions of the body. It's essential that each gene have the correct instructions or code for making its protein so that the protein can correctly control how quickly a cell grows, um, and how often it divides and how often it lives. So if you think about it, they really control how a cell works. DNA are genes that are made up of deoxyribonucleic acid, also known as DNA. These consist of adenine, guanine, cytosine, and thymine. DNA stores genetic information, encodes the instructions for synthesizing specific proteins needed to maintain life, and it dictates the rate of which body proteins are made. Every somatic cell in a person's body has the same DNA. The information in DNA is stored as a code made up of four nitrogenous bases, which are the four components of the DNA: A, G, C, and T. Human DNA consists of about 3 billion bases, and more than 99% of those bases are the same in all people. Um, it's kind of similar to the way that the alphabet are used to create words and sentences. The order or sequence of the bases determines the information for building and maintaining an organism. The DNA bases pair up with each other, A with T, C with G, to form units called base pairs. Each base is also attached to a sugar molecule and a phosphate molecule. Together, a base, sugar, and phosphate are called a nucleotide. These nucleotides are arranged in two long strands to form a spiral called a double helix. As you can see in this picture, that is a picture of the double helix. DNA can replicate and make copies of itself. Each strand in the double helix can serve as a pattern for duplicating the sequence of bases. When the cells divide, each new cell needs to have an exact copy of the DNA that was in the parent or original cell. The chromosomes in one of your cells were uncoiled and placed end to end. If they were, the DNA would be about 6 feet long. If all the DNA in your body were connected, it would stretch about 67 billion miles. So if you think about it, that's a lot of molecules, right? So now we get into a little bit of chemistry here and a little bit more biology. So we're going to talk about mitosis briefly. This is a type of cell division that results in the formation of genetically identical daughter cells. As you can see the different phases. I am not going to test you on the phases of mitosis. This is just an FYI. Meiosis occurs only in sexual reproductive cells. So, in meiosis, the number of chromosomes is reduced, resulting in half the usual number of chromosomes. Therefore, oocytes and sperm contain only a single copy of each chromosome, whereas all other body cells contain duplicates of each chromosome. Mutations. This is where the good stuff begins. Mutations is any change in usual DNA sequence. You have germline mutations. These are inherited from parents, present in cells from birth, and can be passed on to offspring. Acquired or somatic mutations, these are acquired during a person's lifetime in specific non-reproductive cells. They are not inherited and cannot be passed on. And then polymorphisms account for subtle variations among people, such as hair color and eye color and things like that. Um, you should know this slide. Single gene disorders such as cystic fibrosis and sickle cell disease are an example of a mutation. Mutations can also be chromosomal disorders such as Down syndrome, which is the trisomy 21 gene. And then you have multifactorial inherited disorders such as the BRCA1 gene, cleft lip and cleft palate, and hip dysplasia are all examples of multifactorial inherited disorders. And I know we just talked about that in lecture last week. Um, and it's interesting to note that these really are inherited disorders. My sister was born with hip dysplasia and had to have it corrected at Shriners Hospital. And then her daughter, not her sons, her daughter was also born with hip dysplasia, and she had to be in a spica cast as a child. So it's interesting how these disorders are inherited. Um, and anyone who's had any experience with anyone with breast cancer, They usually test for the BRCA1 gene, so that they can determine whether or not future offspring of whoever the patient is could be affected. When do we use genetics? This is important to know. We use genetics a lot in prenatal testing, so we can see what abnormalities may be present and could determine the viability of the fetus. Pharmacogenetics. We use genetics to simply make medications that will work on a lot of these disorders. Um, Genetics are also used in forensic nursing and to determine paternity. Um, Perfect example is, if any of you guys ever watch any of those true crime stories, they do DNA testing, blood typing, things like that. And then legal identification to determine whether, what's that show? I think it's Maury Povich or something. You are not the father. So, um, they can determine paternity that way as well. Um, they are predicative. They can predict the probability of disease occurring in the future. Um, we also use genetics to rule out specific conditions. So we use it in diagnostic testing. Um, and we use it in carrier screening a lot to determine if, like when we talked about sickle cell disease, if both parents are carriers, then the child has a 25% or a significant chance of becoming a victim of sickle cell disease. So that's why we use it for that. And that's the end of our basics on genetics. Because this is a recorded lecture, if you want to reach out with any questions, feel free to email me and I will answer them as soon as possible. I will see you in a few minutes for the next part of the lecture. Hi, everyone. Welcome back. For this part of the lecture, we are going to be talking about immunology. And basically, we're going to be reviewing HIV, cancer, organ transplant patients, and immunosuppression related to immunology. I'm not going to get into a lot of details about a lot of these things. The most, the biggest thing I'm going to be detailed about is HIV because I don't believe that that has been covered extensively, and I want to make sure that you are able to care for these patients effectively. But I also want you to see how all of this is related. All right. All right. So first we're going to talk about immune functioning. So when we're talking about the immune system, we have to think about the major components of the immune system. This includes bone marrow, white blood cells, lymphoid tissues, including the thymus, the spleen, the lymph nodes, the tonsils and adenoids, and the smaller tissues in the GI system, as well as the small tissues in the reproductive, and respiratory systems. So when we're talking about the immune system, we are talking about lymphocytes primarily. There are B lymphocytes known as B cells. These are found in mature bone marrow, and there are T lymphocytes called T cells. These move from bone marrow to thymus, where they mature into several kinds of cells with different helper functions. If you think about lymphocytes, they are white blood cells that are super important to the immune system and are responsible for fighting infections, viruses, and cancer throughout the body. This is a really good picture of the immune system overview. So, if you want a good idea of what parts of the immune system, and they are all important parts, this is what you need to look at. So, when we talk about immunity, we are talking about active immunity versus passive immunity. So, active immunity is when you are exposed to a pathogen that triggers an antibody production. This can either be natural via infection or artificial via vaccine. When you talk about passive immunity, this is when a person is given antibodies rather than producing them. So this can either be by babies receiving these antibodies maternally while in vitro or via breastfeeding. Um, or monoclonal antibodies, which are often, people receive in blood transfusions and things like that. Means of defense. These are important defense mechanisms that the body uses to fight, like I said, diseases, viruses, infections, things like that. The white blood cells, which are composed of granulocytes and macrophages, have the ability to ingest foreign particles. That's their job. That's what they do. That is phagocytic immune response. Then you have humoral or antibody immune response. This begins with the B lymphocytes, also known as the B cells, which transform themselves into plasma cells and manufacture antibodies. Then you have the cellular immune response. This is where the T lymphocytes turn into, also known as the T cells, turn into cytotoxic or killer T cells that can attack pathogens. When we are doing an assessment of the immune system, this is what we're looking at. We always want to look at a health history, um, where we're listening to common complaints from the patient. What is their past history? What is their immunization status? What is their allergy status? Do they have any autoimmune disorders? Any chronic illness and surgery history? Do they have any special problems? How is their nutrition? Are there meds that they're on? Do they have a history of blood transfusion? We always want to know what they do for an occupation to see if there's any occupational hazards, or if they have any travel history where they could have been exposed to something. And then we're looking to ask about personal and or family history of cancer. Then we move on to the physical assessment. This is where we are essentially doing a head to toe. We're looking at the respiratory, the cardiovascular, the GU system, the skin, the eyes, ears, nose, and throat, and for any signs of infection, where you're looking at somebody's joints. Are they swollen? Do they have swollen lymph nodes? Things like that. Um, refer if you want, well, not if you want to, you should refer to table 35-4 in your book. It is your med surge book. I think it's Honan. Um, because this will give you a list of selected medications and effects on the immune system. And a lot of these medications are pertinent to what we're going to talk about. So you should at least review that list, please. Moving on to immunodeficiencies. These are diseases that are genetic in origin and manifest most commonly in infancy and childhood. Those are what we call primary immunodeficiencies. So, the important difference to remember between primary and primary usually is genetic in nature and manifests most commonly in infancy, childhood. And when I say usually, that doesn't mean everybody, every person is different, but the majority. Secondary immunodeficiencies, this results in increased susceptibility to infection and certain types of cancer. There can be both extrinsic and intrinsic factors that can trigger this. So, when we're talking about immunology, um, allergies factor in. A lot of people have allergies. I know right now, spring is here. It is the seasonal allergy time. I see multiple people walking around with tissues, with the sniffles, watery eyes, seasonal allergies, things like that. But people can have an allergic reaction to just about anything. An allergic allergies are simply an amplified or inappropriate response to an antigen, leading to inflammation and or destruction of healthy tissue. These can result from genetic, hormonal, and environmental factors. When somebody has allergies, we always want to be on the lookout for anaphylaxis. Anaphylaxis can occur from just about anything, an allergic reaction to an extrinsic or an intrinsic factor. An allergic reaction to a medication is a good example. Anaphylaxis is a clinical response to an immediate type of hypersensitivity. Um, the immunologic reaction between a specific antigen and an antibody. That's basically what it is. It occurs when the body's immune system produces antibodies toward a substance that is normally non-toxic. Reingestion of the offending substance, so reingestion, re-exposure, results in the release of excess amounts of histamine. Substances that most commonly cause anaphylaxis include food, medication, insect stings, and latex. The symptoms of anaphylaxis may be mild, things such as wheezing, swelling, itching, or they can be moderate. They can have moderate wheezing, sneezing, itching. Um, but it's important to know that those can progress rapidly to bronchospasm, laryngeal edema, severe dyspnea, cyanosis, and hypotension. Um, it's important when somebody has a moderate to severe reaction to something, they need to have strict avoidance to that allergen. This is a vital preventative measure. Patients who have severe allergies and are subject to increased risk for anaphylaxis should carry an emergency kit that should contain antihistamines and or epinephrine, depending on the severity of the reaction. Epinephrine, this is important to know, is the first line treatment for anaphylaxis because it rapidly reverses airway swelling, hypotension, and bronchoconstriction. Antihistamines and steroids are secondary treatments. And always remember when you're thinking about anaphylaxis to remember that a assessment of ABCs, airway, breathing, circulation, is a priority nursing assessment. And we all know that Dottie loves nursing priorities, right? So keep that in mind. ABCs. All right, so now we're going to move on to HIV. HIV, also known as human immunodeficiency virus. Um, it's important to know there are more than 1.2 million persons living with HIV or AIDS in the US. There are 37.7 million people living with HIV/AIDS in the world. Worldwide, there are 1.5 million new infections just alone in 2020. But they have seen a reduction of 25% over 2014, since 2014. So there has been a reduction. The rate of new infections in males is 5 times greater than in females. Um, the infection rate is greater in males having sex with other males. This counts for overall at 69% of newly diagnosed cases. And 81% of men with a new HIV diagnosis accounts for a great deal too. Transgender people account for 2% of new HIV diagnoses, with 93% among people that identify as male to female. Transmission of HIV. When HIV first became well known to communities, people were very, very afraid. They were afraid to touch other people. They were afraid to interact with other people. But what we do know is HIV is bloodborne. It's sexually transmittable. It's a bloodborne, sexually transmittable virus. So we need to use standard precautions. HIV is not transmitted through casual contact. Blood and blood products can transmit HIV. Prevention and education are vital. The emergence of HIV prompted implementation of standard precautions and the need for post-exposure prophylaxis. It's important to know that HIV in middle-aged and older populations may be underreported and underdiagnosed. And this is because HIV-related dementia in the older population may mimic Alzheimer's disease. So when we talk about post-exposure prophylaxis and things like that, um, it's super important that we continue on with things like this, so that we are treating our patients appropriately. Risk behaviors associated with HIV, these can include sharing injection drug use equipment, um, having sexual relations with infected individuals, both male and female, receiving HIV-infected blood or blood products. This is especially before blood screening was introduced in or instituted specifically for HIV in 1985. Or being born to a birthing parent with HIV who is not taking antiretroviral medication. These medications are called ART medications, and they work by stopping HIV from making copies of itself. We kind of talked about that when we were talking about genetics, right? ART medications are a combination of daily meds that reduce the viral load. This prevents transmission and suppresses HIV to an undetectable level. These medications include, and you may have seen the commercials for them, which I love that they're doing, medications such as Biktarvy, Truvada, Descovy. These are common ART meds. It's important to do a lot of patient education with patients taking ART meds, because they must be taken consistently and lifelong to suppress the viral replication. Missing doses can lead to drug resistance. It's important also for patients to know that ART medications control HIV, but they do not cure it. Stages of HIV. Primary infection. This is characterized by intense viral replication. HIV systematic. This is usually by asymptomatic, sorry. This is by approximately 6 months, where the rate of the viral replication reaches a lower but steady state. Then you have HIV symptomatic, where you see the number of T cells gradually reducing. And then you have AIDS, where the T cell level drops below 200 cells per mm. So HIV manifestations and complications. Respiratory, the respiratory system is affected. This can include dyspnea, cough, chest pain, fever, and complications from this include pneumocystis pneumonia and tuberculosis. The GI system is affected, loss of appetite, nausea, vomiting, oral and esophageal candidias, and chronic diarrhea. Complications from this include wasting syndrome, which is a severe involuntary loss of muscle mass, weight, and fat. Oncology manifestations can occur, and these complications can include Kaposi sarcoma. Um, this is a cancer that develops in the lining of the blood or lymph vessels. Um, and it typically forms purple, red, or brownish tumors like lesions on the skin, in the mouth, or in the internal organs. And then B cell lymphomas can occur. This is a type of blood cancer that originates in the lymphatic system when white blood cells, the B cells, grow abnormally and divide uncontrollably. The neurological system can be affected. This involves central, peripheral, and autonomic functions. Encephalopathy or HIV associated dementia can occur. Um, cytomegalovirus can occur. Depression, skin changes, as well as gynecologic changes can all occur. Education and prevention are super important with HIV. Um, there has been initiatives advancing HIV prevention called AHP. It comprises four strategies. We are encouraging safer sexual practices. Um, we are, and this decreases the risk of transmitting HIV infection to sexual partners. Um, we are encouraging the importance of avoiding sexual practices that might cut or tear the lining of the rectum, penis, or vagina. And sexual contact with multiple partners or people who are known to be HIV positive or IV injection drug users. Um, then the third strategy is to get people at an undetectable viral load, which is defined as at least 6 months of undetectable viral loads after starting the ART medications. Um, and needle exchange programs can help this. I know Tapestry Health does a lot with this. Um, and I know that Holyoke has a needle exchange program. So pre-exposure prophylaxis is an important measure too. Um, this is often called the PrEP medication. It's a combined pill of tenofovir and I'm going to try and pronounce this and not crucify it. Tricabine, and those are taken, I just call them PrEP meds. These are taken daily to prevent HIV infection amongst high-risk people. Um, there is a new formulation of PrEP that is now available as an injection every 2 months. These patients they have to commit to medication adherence and regular follow-up with their healthcare provider, because this increases adherence rates. This is also related to reproductive education. Women who are HIV positive with a detectable viral load should be instructed not to breastfeed their infants because HIV is transmitted through breast milk. We're also encouraging a lot of comprehend contraceptive methods, things such as condoms and things like that. Those can also be pre-exposure prophylaxis. When we talk about post-exposure prophylaxis, this is for like people who know they've been exposed either via needle stick or some other form. This includes standard precautions and prevention of further needle sticks. Um, Prophylaxis for healthcare providers post-exposure. Um, this should be started immediately after exposure and lasts for at least 4 weeks. Usually therapy started more than 72 hours after exposure is thought to offer really no benefit um, to rapid increases in the viral load. And now we are going to move on to cancer. So, when we are talking about cancer, and I know we talked about cancer screenings and things like that earlier on in the semester, but now we're talking about cancer in relation to immunology. So, cancer is defined as uncontrolled cell proliferation stemming from genetic mutations that disrupt the normal cell regulation. So, as you can see at the picture on the right, there's a picture of normal cells and there's a picture of cancer cells. This begins with DNA damage from carcinogens, radiation, or errors during mitosis. Um, this creates mutations in genes that control the cell growth. Treatment consists of chemotherapy, surgery, radiation, targeted therapy, or immunotherapy. Chemotherapy, most chemomeds are absorbed through the skin and mucous membranes, and anyone handling or administering them needs to wear the proper PPE. That's the most important thing you can know if you are administering any medications that are cytotoxic. And you need to know which ones are and which ones aren't. I know at Holyoke Medical Center, they have new labels they put on the Pyxis as to, um, clearly identifying whether a medication is cytotoxic or not. Um, it's important to know too that many of these cytotoxic medications can be used for other disorders. So don't just think about it in relation to cancer. When I'm talking about medications like that, I mean medications like methotrexate, which is cytotoxic, and very often used in lower doses on a weekly or biweekly basis, or even monthly, for patients with rheumatoid arthritis and things like that. Central lines are preferred when administering chemotherapeutic medications. We don't want to put those in peripheral lines because they are cytotoxic and can really damage the smaller vessels. So, and it's always important to think about nursing considerations. We want to closely monitor people during infusions for infiltration. Um, because, like I said, these are cytotoxic medications and they can destroy very quickly. Immunosuppression. That's really what chemo does. It suppresses the immune system by killing the cells. Um, when this happens, neutropenia can occur. Usually, this occurs due to bone marrow suppression by cytotoxic substances. And this is the most adverse effect of chemotherapy. Um, so it's important to know when you have patients taking cytotoxic medications that you need to monitor for neutropenia. Um, and I can't stress this enough. You want to make sure you are doing all your rights and all your checks when administering all medications, but especially this. I had a patient quite a few years back who, when he was admitted, there was a medication error made. He was taking methotrexate for rheumatoid arthritis. He was supposed to be on the medication once a week. And the nurse who did the med reconciliation, and this was a while ago before we had computerized scanning and things like that. Um, but the nurse and who did the med reconciliation wrote down that he needed that methotrexate daily. Um, so unfortunately, it wasn't discovered until almost a month later when myself and another nurse were assessing the patient and noticed signs of neutropenia and then started looking at things. Um, so it's really, really important to monitor for these things. Nursing considerations to consider. We want to look at temps. We want to look at white blood cell counts. And we want to look at absolute neutrophil counts. These are really, really, really important with neutropenia. Um, we are we're always looking at skin and mucous membranes for signs of infection. Always remember cultures before antibiotics. And it's important to know the risk of infection increases as the ANC decreases. If the ANC is less than 1,000, the nurse should implement neutropenic precautions. And that's exactly what we had to do for that patient. We had to implement neutropenic precautions, and he eventually needed to go out for a transfusion. So this is more on neutropenia. Like I said, an ANC of less than 1,000 cells. Um, it's considered severe when the ANC is less than 500. Normally, neutrophils range between 4,000 and 11,000. Um, this is not any kind of new math that you're going to be tested on, so I just wanted you to be able to figure it out. Um, you may need to know it for next year. To find the absolute neutrophil count, you multiply the WBCs by the percentage of neutrophils and then divide by 100. What you're going to see when a patient has neutropenia, um, and what you need to monitor for is the presence of a low-grade fever. This is significant because it may indicate infection and lead to septic shock and death unless it's treated promptly. Um, you also want to monitor for neutropenic fever. Um, this is when a patient has a fever greater than 100.4 Fahrenheit, and the neutrophil count is less than 500. This is a medical emergency. And one of the medications that can help with this is a medication called Neupogen. Um, so like Neupogen's kind of important. A lot of patients are often placed on it as a prophylactic. We talked about neutropenic precautions a little. This is stuff you should know. This is important. Anybody on neutropenic precautions should be given a private room, and they should be wearing a mask whenever they are leaving that room. Um, Hand hygiene is huge. We want to encourage the patient to be, you know, performing good hand hygiene as well as anyone going into the room. These patients cannot have visitors that are sick. They will catch an illness very, very quickly. We do not do rectal temps, Foley catheters, or injections, if at all possible, on these patients. They need to have dedicated equipment. In other words, we're not going to bring the blood pressure machine into the room. They're going to have their own dedicated blood pressure cuff and all their own equipment in their room that's going to be used solely on them. And we want to encourage factors to increase the WBCs, such as Neupogen. These patients cannot have fresh fruits or vegetables or any undercooked meats. Um, No fresh flowers or plants, and they need to be encouraged to shower daily. And now we are moving on to organ transplants, and I promise that we are almost done. So, an organ transplant is a medical procedure in which a damaged or failing or even missing organ in person's body is replaced with a healthy organ from another person. And this person can either be alive or recently deceased. And that person's called the donor. Um, it is done to save or greatly improve the patient's life. Um, when their own organ can no longer function properly. Organs that are commonly transplanted include the heart, kidneys, liver, lungs, and pancreas. After the transplant, it's important to know the recipient must take special medications to prevent their immune system from rejecting the new organ. The body will recognize it as foreign and reject it. You see on my slide here, there's a little picture of Donate Life. I I work a lot with a friend of mine who is a recipient of a transplant. She has a kidney and a pancreas, and she raises a lot of money for Donate Life. Um, to provide for patients who are either on waiting lists or can't work or for whatever reason. And down below that is a website if you are interested in becoming an organ donor. This will give you ideas on how to become one. I'm one. I believe in it wholeheartedly. If we're not surviving, we don't necessarily need them anymore. That's my thought, but um, a lot of people don't want to be organ donors, and that's okay too. And that is it for me. Like I said on the previous one part on genetics, if you have any questions, feel free to email me or reach out in class. I'm happy to answer wherever I can. And don't forget to take your quiz. It will be open after exam 3. Um, and you have until Saturday at midnight to complete it. I hope you all have a great rest of your day. And please remember, this is week 13, which means we have 3 more to go. Keep on the right track and keep your chin up, and y'all got this. I have faith. Have a great day, everyone.